This is Group 3's case study overview for anxiety and mood disorders by Rebecca, Abigail, and Amanda. This presentation will cover the history and background, behavioral observations, clinical interpretation, diagnostic impressions, as well as treatment plan, interventions, summary, recommendations, ethics, and limitations of treatment and supervision of Mary. Mary is a 45-year-old Italian-American female. She is currently married, separated, and living with her husband. They have 3 grown kids who no longer live at home. Mary currently works 2 part-time jobs, one at the local shopping center and the other as a waitress. She wishes to complete her schooling by studying business administration, yet she is currently deferred in order to work while her husband's disability income begins. Mary's presenting problem and the reason for her counseling is due to an increasing feeling of hopelessness, stress, worry, and fear about the direction of her life. She expresses feeling too bogged down in her problems, which hinders her ability to see where she should be going. Although these feelings are increasing, there has been a history of them in her life. Mary had a traumatic childhood, which included many times without having food, a father addicted to pills, and crying herself to sleep. She was kicked out of her parents' house at 18 and moved to college. However, while in college, she became sexually active and married at 20 because she became pregnant. In her adult life, Mary attempted suicide 5 years ago. She pursued counseling for this, but quit treatment early because she felt as if it wasn't helping. Her husband has had many affairs, which caused her to contract an STD. In the past, he has also physically abused her on multiple accounts. Concerning relevant behaviors, Mary dresses appropriately for counseling sessions and holds herself well. She acts shy and especially agitated when talking about her childhood experiences. Aspects to notice about her life, which she has shared during sessions, are that she still lives with her husband, she shares incomes with him, and they remain intimate even though they are separated. School is a priority for her. However, she has had to put it on hold in order to provide for her husband. An especially important point to note is how Mary comes alive when interacting with individuals who have the same interests as her. Unfortunately, due to her current circumstances, this does not happen often. Observing Mary during the counseling sessions has led us to conclude the following about Mary's mental status. As stated, Mary dresses appropriately for counseling sessions and holds herself well. She speaks clearly and professionally at most times, except for when talking about her experiences as a child. Mary seems to have a positive attitude toward the counselor despite her generally sad and somewhat neutral mood. Clinical interpretation. Having interviewed and conducted a few sessions with Mary, we have observed that her experiences throughout her life have caused her brain to work in a specific way. There seems to be a chain reaction since she experienced trauma in her childhood. We can see patterns of behavior resulting from this trauma due to the ways it has shaped her to view the world and the others around her. Mary seems to make sense of the world through the lens of her traumatic childhood experiences, which causes the problems she describes. Because of her experiences, Mary feels hopeless, and she has not yet attached positive meaning to the sufferings she has experienced. According to the American Psychiatric Association Diagnostic and Statistical Manual of Mental Disorders, 5th edition, the diagnosis for PTSD seems to be the most appropriate for Mary. Listed on this slide are the specific criteria that has brought us to this diagnosis. There's been exposure to actual or threatened death, serious injury, or sexual violence. There's been presence of one or more intrusive symptoms associated with a traumatic event. There's been persistent avoidance of stimuli associated with the traumatic event. There's been negative alterations in cognitions and moods associated with the event. There's been marked alterations in arousal and reactivity associated with the traumatic event, and the duration of disturbance has been greater than 1 month and has caused clinically significant distress or impairment in her social, occupational, and other areas of functioning, and the disturbance has not been attributed due to substance abuse. There's been no dissociative symptoms present with Mary, but she also fits into the risk and prognostic factors of pre-traumatic, peri-traumatic, and post-traumatic factors. PTSD is more prevalent in females, and PTSD also holds a risk of suicide, which she has previously attempted 5 years ago. A differential diagnosis could be adjustment disorder or major depressive disorder. She also did experience childhood neglect and physical violence from her spouse, as well as mild alcohol dependency. The rule-in, rule-out process would be essential in justifying Mary's diagnosis. This would be done by questioning Mary in relation to each diagnostic category and targeting what information is important to pursue in terms of the client's reported symptoms and observable signs. The limitations of a diagnostic interview are the validity and reliability of the questions asked and answers given. Mary is relatively stable in day-to-day life. She has a strength in holding 2 jobs and has ongoing interest in business administration. She took a personality inventory and seemed to appreciate the results it yielded. Mary seems motivated to pursue her interests in business, as witnessed by a recent seminar attendance. Mary acknowledges her excessive alcohol usage. Mary needs to become independent from her husband. He has requested a divorce, but they continue to eat, watch TV, and be intimate with one another. She needs to create boundaries in this relationship or leave it altogether. Mary needs to figure out a plan financially to continue her studies. Mary needs help with her alcohol consumption. Mary is a good worker and currently holds 2 jobs. She also is a motivated student with a huge interest in pursuing a new career within the field of business. She prefers to become independent with her husband, but is unsure how to be. Mary longs for having a social life, and she wants to stop over-consuming alcohol on the weekends. Currently, Mary is experiencing feelings of hopelessness, stress, worry, and fear about where she is headed in life. Her isolation from others is hindering her progression, as well as her dependence on her husband, despite the physical abuse. Mary has stated 3 goals. She wishes to get unstuck from her current situation with being separated from her husband, but still living in the same home. She is seeking guidance and help with finding herself in her social circle. And she is also looking for help with her alcohol dependency and wants a new coping strategy that brings comfort. Her relationship issue with her husband and the separation while living in the same home is a problem. We've established a goal for her, which is to reassess marriage dynamics and to establish boundaries within the relationship, as well as discuss potential financial alternatives. A good treatment strategy for Mary would be to engage in couples therapy if she wants her marriage to continue. Her lack of social life and isolation has led to goal number 2 of increased social interactions, where she can initiate at the beginning 2 social interactions a week and lead to 4 social interactions a week. Exposure therapy is a good treatment strategy. Her alcohol dependency has developed goal 3 to develop an action plan directed towards termination of usage of alcohol, as well as develop an abstinence contract and attend AA meetings, and to engage in activities to increase satisfaction in non-drinking areas of life. Cognitive behavioral therapy, as well as the 12-step program, would be good treatment strategies. Mary's childhood trauma and current trauma in abusive relationship. Mary needs to refine and understand her traumatic events by putting her life events into context. Narrative exposure therapy is a good treatment strategy. While conducting a study linking childhood trauma to adult psychiatric diagnosis, McCormick and Thompson found that participants who had experienced childhood trauma commonly struggled to establish a sense of self, which endangered both their ability to form and maintain relationships, but also in managing their emotions. Mary has been able to progress in multiple areas of her life, although she will benefit from continued counseling sessions. Mary and her husband have attended couples therapy sessions regularly for 8 sessions. Emotionally focused therapy has been effective for Mary and her husband, and they are currently in phase 2, the change events phase, starting step 6, which is promote partner acceptance. Continuation and completion of this therapy through phase 3, step 9, would be vital to continued healing and growth in their marriage relationship. Mary's social life continues to struggle. She started strong in exposure therapy to meet goals regarding social interactions on a weekly basis. She seemed to plateau at 4 interactions a week and continues to feel not particularly social. Mary's previous personality assessment that revealed she was a D type continues to prove accurate, as the social interactions she derives the most from tend to be those that focus on a common interest. Continued immersion into settings that are social and involve business interests will likely prove the best prospect to enlarging Mary's social circles. Mary has been able to discontinue her use of alcohol. Mary has been attending AA meetings once per week on the weekend when her cravings have been the most difficult, and has engaged in the 12-step program. A combination of the emotionally focused couples therapy and cognitive behavioral therapy has allowed Mary to approach her problems with healthier, strategic ways of thinking and communicating. Mary's husband has been a positive support in Mary's sobriety, even joining her in a yoga and meditation session 2 nights per week. Mary should continue with cognitive behavioral therapy, the 12-step program, as well as continue participation in yoga and meditation. For her 4th problem of childhood trauma, while EFT couples therapy is helping Mary progress in processing the past traumas of her marriage, she is having difficulty working through the trauma she experienced as a child. Employing a new treatment strategy may be needed to help Mary process her childhood trauma and move on from it. Eye movement desensitization and reprocessing may prove a useful approach for Mary in the future. In reference to the ACA Code of Ethics, the following 3 codes come to mind regarding Mary's case study: A4B, C6, and EFB. A4B is imposing values. We have observed Mary's religious affiliation as well as her relationship with her husband. A4B comes to mind concerning personal values because we want to make sure it is clarified with the client if she wishes to be counseled through Christian worldview and prioritizing Christian values. Our own opinions on the steps she should take presents an ethical dilemma, in that we must be careful that by doing so we are not imposing our own values onto her. C6, reporting to third parties. Another code which comes to mind is C6, concerning public responsibility and reporting confidential information to a third-party source. The abuse Mary has received from her husband is a major concern, and we must contemplate the response that it demands. It is essential for us as Mary's counselors to consider other professionals we may need to consult or report to in order to best address this issue. E5B, cultural sensitivity. A final code we must consider as Mary's counselors is E5B, concerning cultural sensitivity. Mary mentions briefly that she is an Italian American. A priority before getting far into the process of counseling with her would be to observe what the possible cultural differences may be. We would not want to assume an awareness of her cultural values and cues, and therefore we would make it a point to be educated on the Italian culture she comes from. Limitations of treatment and supervision. In every case, 2 heads are better than 1, and regarding Mary, there are things we need from others in order to provide our best counsel. From faculty, we need additional resources or information that is relevant to Mary's case in order for her to be guided down the most appropriate path for her situation. Our classmates will offer life experiences and knowledge from other sources and courses that will be beneficial for a grander analysis of Mary. This presentation gives us insight on how extensive each individual case and counseling is, all the components to consider and address, as well as the avenues that can get us from point A to point B, as well as the amount of patience and time it takes for real healing to occur. Limitations include a plethora of factors that are not controllable by the counselor, or even Mary at times. Treatment can only reach the extent of Mary's actions, willingness, and her environment. No matter what is focused on during sessions, the real work is done when Mary is at home and in the challenging moments, which as counselors we are unable to guide her every step of the way, but instead lead her into the light and love of God. You, Lord, keep my lamp burning. My God turns my darkness into light. And that is the end of the slideshow. Thank you.